Hi, this is Brian Kim. I'm going to share with you case 89 in the best way to do cataract surgery series. This is a white, soft cataract, and you're going to see systematic lens disassembly using double chop, cross chop, mechanical fraction forces, utilizing the chopper to hook lens pieces up out of the bag rather than fishing for it with the phaco tip and potentially going near the posterior capsule and iris with high vacuum. So you can see this is the lens. It's pretty white. I'm using a cotton tip to steady the eye. I'm using a corneal marker, which will help me to make a little impression, which will hopefully help me center and size my rhexis. Using the cotton tip to turn the eye so I can make a flat approach for my paracentesis incision, first on the right side and then the left side. This creates a nice platform and a shelf so I can hydrate my incisions through that shelf, and this will really allow me to achieve a really nice self-sealing incision. This is some intracameral lidocaine, and then now some intracameral air. And this is the trypan blue I'm going to use to paint the anterior capsule surface. I try not to flood the eye with trypan, but you saw here that the anterior chamber kind of collapsed and the pupil collapsed. I had to irrigate the trypan blue out. And then this is intracameral epinephrine. So I put that epinephrine in because this might be a floppy iris situation because of the way the chamber and the pupil collapse down. After I inject the dispersive viscoelastic, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. And I use a cannula to control the eye while I do this maneuver. I inject some more viscoelastic at the end. And this is going to be the puncture style technique in case this is an intumescent lens. I'm using a 25, 27 gauge needle. It doesn't really matter. You just need something sharp and that has a lumen so that you can quickly aspirate when you do this maneuver. So I go ahead and puncture and then I aspirate. But as I aspirate, I don't see that plume of milky white material. And so this tells me this doesn't seem like an intumescent lens. So I go ahead and extend the tear and create a little bit of a flap with the needle. I'm going in with the teeth sideways, and then this is my rhexis forceps. Even though I didn't see a plume, I'm still going to be mindful about any potential radialization there. So I'm going around circumferentially. And with these lenses, I tend to make the rhexis a little bit smaller than larger between the two. I hedge my bets towards a smaller pupil here. Again, just in case it wants to radialize. So I'm going around circumferentially, grabbing and re-grabbing, carefully making sure I have good control of the rhexis as I go around. Okay, and that's the rhexis. Burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave. Of course, you can't see it because it's white. I try again, try to decompress, and then the lens begins to spin. Even if I don't really get a good wave, the way I'm able to use a cannula to hook the lens and rotate is really advantageous there. Irrigate the surface of the eye, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, remove the surface epinuclear material, placing the chopper underneath the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, bringing both instruments together, and it divides the lens. You can see it's a pretty soft lens. It just fragmented pretty easily. Take the chopper around the right heminucleus, pulling it centrally, using some vacuum, lifting up that quadrant, and then carefully emulsifying it. The rest of that lens stuff kind of fell apart, so I'm going to go after the second heminucleus. I'm gingerly rotating it in front of me there. Place the chopper around the lens, pulling it centrally toward the phaco tip, making sure the phaco tip is deep in the bag so it fractures the lens effectively, and then emulsifying that lens piece. Rotating it a little bit more with the chopper, getting around the lens with the chopper, pulling it centrally toward the phaco tip, and again dividing that lens piece, grabbing it with some vacuum, fracturing it again, and then emulsifying it. As you can see, I make it a habit not to go after the pieces with the phaco tip. With such high fluidics, you just don't know, and you might be able to grab the posterior capsule if you're not careful. So now I have a thick epinucleus. I'm going to try to mobilize it with the chopper. I did, and then now I'm able to remove it. Now this subincisional stuff is tricky. I could try to go after it with the INA, but this is what I'm going to do. I'm going to go underneath subincisionally, hook it, and then lift it. So that's a really neat trick there. I'm able to just use a chopper to pull that subincisional thick piece of epinucleus out. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. There's a big chunk of epinuclear material there that I was able to remove with the INA handpiece. I'm polishing underneath the rhexis edge. Quite a dirty bag still, so I have to really pay attention to remove that cortical material. When it's that kind of lens where it's really soft and white and chalky, it doesn't have the typical strands of cortex that you peel like an orange peel. It's a little bit less organized, and so you have to be mindful of going around 360 degrees, getting every little bit of cortical material. In these cases, you're more likely to miss a little bit of that material there. So I'm going to go in subincisionally with the BSS cannula and pulse. Oh, there's a little bit of stuff right there. So you saw that. And so I go after it. So again, to my point, you just have a higher likelihood that there's some remnants around. You just have to be mindful going around and cleaning it up completely. So I'm injecting some cohesive viscoelastic to fill the bag. And then I'm going to use the sweep to polish underneath the rhexis edge. First on the left side and then now on the right side. Does a really nice job removing those lens epithelial cells. And this is a single piece acrylic intraocular lens. I'm going to go ahead and inject the leading edge into the capsular bag. And while the lens is unfolding, I quickly transition to the INA. I go in with irrigation off, activate irrigation, disengage each haptic off the optic, go underneath the lens, tilting it, and then rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag and against the lens. Reposit the lens in the bag, switch to polish mode and polishing under the rhexis edge, as well as rotating the haptics in the horizontal meridian. Switch to visco mode, removing all the viscoelastic from within the anterior chamber, and then I'll hydrate my incision. So you can see this was a white lens. I was mindful that it could be intumescent. That's why we went with the needle by puncturing the center. But as you saw, there was no cortical milk that came out, which tells you it wasn't intumescent. I was able to go ahead and do the rhexis from there, keeping the rhexis a little bit smaller than normal due to these thick white swollen lenses. Carefully broke down the lens using double chop and cross chop. By using mechanical forces, it's quite easy to break down a lens like this, and using sparing amounts of ultrasonic energy. By using mechanical forces to break down the lens, you don't have to go after lens pieces with the phaco tip. And for this reason, in my opinion, this is the best way to disassemble this lens by using mechanical forces, crushing the lens pieces without having to use vacuum. If you go after lens pieces in the bag using vacuum, sometimes you can aspirate the posterior capsule and then have a problem. So I hope this was helpful to you, and I thank you for your attention.